Now that I'm in residency, it has become very clear how different presentations in skin of color can be, and I can really see the importance of proper training in a racially diverse population. And so I think now I can truly appreciate how important this research and this topic really is.
Dermatology residents must be knowledgeable about many things, including dermatologic conditions that present in patients of a variety of ethnic backgrounds. Coming up later on Peer-to-Peer, Dr. Vincent DeLeo welcomes Drs. Abigail Cline, Susan Taylor, and Amy McMichael to talk about improving and expanding multi-ethnic training for dermatology residents. Welcome to episode 72 of Dermatology Weekly, where we bring you the top news in dermatology followed by clinical research and training conversations relevant to dermatologists, those training in dermatology, and those interested in dermatology. I'm the host of Derm Weekly, Nick Andrews. Remember, you can contact the show by emailing us at podcast@mdh.com, and you can interact with us on Twitter at mdhderm. We appreciate 5-star ratings and reviews on Apple Podcasts and take them seriously and incorporate them anytime we improve the show. Coming up later in the news for episode 72, sub-Q Nemolizumab eases itching for atopic dermatitis, and only about a third of older Americans are getting their shingles vaccines. But we begin today with data that showed roflumilast improved the signs and symptoms of chronic plaque psoriasis. The study was Phase 2B, randomized, double-blind, vehicle-controlled clinical trial, and it was presented at the 2020 AAD meeting, which was, of course, held virtually. In the study, researchers included 331 patients with chronic plaque psoriasis who were randomly assigned to receive once-daily roflumilast at either 0.3%, 0.15%, or to the vehicle arm. The primary endpoint of the study was achievement of an IGA score of 0 or 1 at week 6. The observed improvement was dose-related, although both doses in the trial were significantly more effective than the vehicle. Peak improvement occurred at week 8, not week 6, with subsequent plateauing of response through week 12. 32% of patients in the high-dose group experienced an IGA of 0 or 1, and a 2-grade improvement from their baseline. And as of this episode in mid-July 2020, the Phase 3 program is currently recruiting patients. And adding subcutaneous nemolizumab to topical treatments for atopic dermatitis patients significantly improved their itching compared with placebo. This is according to the results of a Phase 3 Japanese study of 215 patients. It was published in the New England Journal of Medicine, and you can find a link to the original publication in the show notes. Nemolizumab, which was a humanized monoclonal antibody against interleukin-31 receptor A, has showed efficacy in reducing the pruritus patients experience with atopic dermatitis. In the study, researchers randomly assigned 143 patients with atopic dermatitis and moderate to severe pruritus to 60 milligrams of subcutaneous nemolizumab, and 72 patients were randomly assigned to placebo, received every 4 weeks for 16 weeks. All of the patients were 13 years old or older with confirmed atopic dermatitis diagnosis and a history of inadequate response to treatments, including topical glucocorticoids and oral antihistamines. At 16 weeks, the scores on the visual analog scale for pruritus significantly improved from baseline in the nemolizumab group compared with the placebo group. The mean changes was minus 42.8% for the drug group and minus 21.4% for the placebo group. Additionally, more patients in the nemolizumab group experienced a score of 4 or less on the Dermatology Life Quality Index, with lower scores reflecting less impact of disease on daily life. And what's more patients in the trial arm achieved a score of 7 or less on the Insomnia Severity Index. Okay, let's look at the safety profile. Researchers reported that 71% of patients in each group reported adverse events, most of which were mild or moderate. The most common adverse event was worsening atopic dermatitis, which was reported by 24% of patients in the nemolizumab group and 21% of patients in the placebo group. The researchers acknowledged limitations in their work, pointing out that the relatively short treatment period was limiting, and the inclusion of patients who were as young as 13 was also limiting. And finally today, a look at vaccination rates for shingles. The number of Americans 60 years old or older who report having gotten a shingles vaccine had been on the rise since 2008 and has leveled off in the past few years. This is according to a new report from the CDC's National Center for Health Statistics. You can find the link to the original report in the podcast notes. For example, the proportion of people in this age group, 60 years old or older, who were vaccinated rose from 6.7% back in 2008, 6%, to 34.5% in 2018. Let's take a little closer look at this report. Rates of people who reported receiving at least one vaccination with Zostavax or Shingrix varied by factors that included being of Hispanic origin, education level, and family income. However, there was no variance between the rate of vaccination among men and women. There are multiple factors that can explain why vaccination rates differ. Non-Hispanic white adults were more likely to report having gotten a vaccine than were Hispanic and non-Hispanic black survey respondents. Non-Hispanic white adults were twice as likely, in fact, at just under 39% compared with about 20% of Hispanic participants and about 19% of black participants. Dr. Kenneth Schmader is a professor of medicine at Duke University. He found these results disappointing. He said that the health disparity regarding lower vaccination rates in Hispanic and non-Hispanic black populations is reported in other vaccines as well, not just in shingles. Dr. Schmader points to the need for better efforts to vaccinate these patients. However, he was glad to see that the shingles vaccine numbers did appear to be going up over time, given how devastating zoster can be in older adults, and given that we have an effective vaccine. And that's it for the latest news in dermatology, Dermatology Weekly. We'll be right back. Welcome back to episode 72 of Dermatology Weekly. I am Nick Andrews. It's time now for Peer-to-Peer with Dr. Vincent DeLeo.
Today we're talking to doctors Abigail Cline, Susan Taylor, and Amy McMichael about multicentric training in dermatology residencies. Can you please introduce yourselves for our listeners?
Okay. Hello, my name is Abigail Cline. I am currently at the Department of Dermatology at New York Medical Center. But when I conducted this research, I was at the Center for Dermatological Research at Wake Forest School of Medicine.
Hi, my name is Susan Taylor. I'm the Sandra Lazarus Professor of Dermatology at the University of Pennsylvania.
And this is Amy McMichael. I am the Professor and Chair of Dermatology at Wake Forest School of Medicine.
Thank you all for joining us today. Your article touches on a very timely and important issue in our country right now. It regards diversity and the need for dermatologists to be educated on how to treat patients of various ethnic backgrounds. You focused your article on residency training. What made you explore this area?
So when I was a medical student, I found myself very interested in skin of color in dermatology because I found that a lot of dermatology educational material is focused on lighter skin and that there is a lack of representation of minority skin tones and skin concerns out there. I actually have recently done another study where I looked through all dermatological textbooks and found that it is representative photos heavily skewed towards lighter skin tones. And so when I was starting my fellowship at the Center of Dermatological Research at Wake Forest, I knew that this was a passion of mine and that with the expertise of Dr. McMichael, I would be able to conduct this research. Now that I'm in residency, it has become very clear how different presentations in skin of color can be, and I can really see the importance of proper training in a racially diverse population. And so I think now I can truly appreciate how important this research and this topic really is.
So thank you. Tell us about your study of the dermatology residents and how their perception of skin of color curriculum was during their training.
So through this survey, I was able to send a questionnaire to dermatology residents all across the country, and I asked them to identify themselves by what region they were in, whether it was Northeast, Southeast, Midwest, Northwest, or Southwest. And I asked them how comfortable they were and what they felt that they would want in terms of training to become competent in learning about skin of color and multi-ethnic skin. And I found that in certain areas, specifically the Midwest and the Northwest, that they really weren't seeing a diverse patient population and that was affecting their learning. People in the Northeast, Southeast, and Southwest tended to see more diverse patients, and so they didn't feel the need for continued lectures or skin of color clinics. but the respondents within the Midwest and the Northwest really wanted to see these patients and really wanted to see what these dermatoses look like in skin of color. And so I thought these were very surprising results, because I feel that there are these patients probably in the Midwest and the Northwest who aren't being seen. One other surprising finding of this research was that residents put a lot of importance on lectures as well as dermatological textbooks for their learning. That was something that I found through one of the questions, that they really put a lot of importance on those. And so I think that really emphasizes the need for better representation within dermatological educational materials to show that there are diverse skin types, and that psoriasis in a Caucasian patient is not necessarily what it's going to look like in someone who has a darker skin tone.
So, Dr. Taylor and McMichael, you guys have been in educating residents for a very long time. So what can you do to help educate dermatologists in what's been pointed out, less ethnic diverse regions of the country?
Well, this is Dr. Taylor, and I think there are a couple of ways to ensure that trainees get adequate exposure to disorders that occur in people with skin of color. And one way to do that is for the home programs to allow their residents to travel and rotate to other programs where they can have firsthand experience diagnosing skin of color. Something as simple as being able to identify erythema in darker skin tones really requires viewing the skin multiple times, and there's some tricks that we can impart. So I think away rotations can be very helpful, as well as conferences where the lectures include photographs of skin of color patients. And as Dr. Cline just pointed out, there is a real need for textbooks to have diverse photographs. So I think those are just some of the strategies that can be used.
I agree 100% with Dr. Taylor's rundown of what can be helpful. I think that we can also utilize those speakers in the dermatology field who have expertise in skin of color, and bring those speakers, as professors, as very experienced practitioners, to the program so that they can interact with residents, they can explain to them how they've trained, why things look differently, how they have changed their regimens based upon these differences. And I think those kinds of experiences, along with longer rotations, such as a 2 to 4 week rotation, can be helpful. I think that also organizations like the Skin of Color Society, which has a scientific meeting each year, can be very helpful to residents if they spend time in the sessions where they can see posters, as well as hear people who are really content experts talking about how different diseases look in patients with skin of color and how those treatments might be changed based upon how you diagnose these patients.
Thank you. And I think that meeting is the day before the Academy every year. Is that true?
That is correct. So the Skin of Color Society meeting is the Thursday before the annual AAD meeting. And it is usually very well attended by medical students. Another offering from the Skin of Color Society is a mentorship program where medical students can go to their website and apply for an opportunity to spend time with a mentor. And the mentor is someone who usually is very well versed and has many patients who are with skin of color. Let me just say the Skin of Color Society also has grants for researchers, whether it is a medical student or a young attending. So that the Skin of Color Society is really making attempts to, and I think is being successful in reducing racial disparities in dermatology through a variety of programs that they have available.
Thank you. So I think some of our listeners may know that Dr. Taylor and I have a long history together. We worked to develop a Skin of Color Center in New York, and now there are many of these Skin of Color centers around the country. Can you tell us how that might impact or has impacted the training of dermatologists in treating skin of color patients?
Well, the Skin of Color centers throughout the United States provide a perfect opportunity for students to rotate through and see large numbers of skin of color patients. It also provides an opportunity for trainees to see patients who are very satisfied with race concordant visits, that is, the patient and the provider are of the same racial group, so they can observe what goes into making that type of interaction very successful and rewarding for the patient.
So at these centers around the country, are there opportunities for medical students to do rotations, or are there fellowships available focusing on skin of color?
Yeah, that's a great question. Actually, Rachel Tull and myself have just had an article that was published in the JAD discussing those ethnic centers. I think Dr. Taylor also on that article. She had the idea to look at this some time ago with one of her mentors, and then Dr. Shadi Koresh had an idea to look at it. And so we decided to put our efforts together and really take a look at what is out there. And we found quite a number of these skin of color centers, although they're not all called skin of color centers, called ethnic centers. And each one really has its own sort of fingerprint, if you will. So some of them are really about research. Others are research and clinically focused. But I think that no matter which one you're looking at, they really are serving a purpose in the department in which they're housed. They're allowing patients to feel very comfortable going to seek care, because even if many others in the department aren't familiar with skin of color and the ramifications of taking care of patients with skin of color, the people that are running the centers are. So they're able to get, as Dr. Taylor said, race concordant visits, and from people who are really at the top of their game and understand what's out there in research and also understand what needs to be done clinically. So in many cases, there are mentorships available, there are opportunities to rotate, there are opportunities to even do research from afar if, you know, we're in a time when students aren't able to travel. So I think there are a significant number of opportunities from just simply seeing these ethnic skin centers pop up really after the very first one in New York, founded by both yourself, Dr. DeLeo, and Dr. Taylor.
We all know that Dr. Taylor took a further step and helped to organize a Skin of Color Society, and we've been talking about that. Do you think the society has done a good job in helping to reduce racial disparities in dermatology?
I think there's no doubt about it that the Skin of Color Society has helped to reduce racial disparities in dermatology. And that ranges from mentorship programs, observership programs that we talked about, to the ability of residents and young attendings to do research, to being able to interact with dermatologists during the meeting that we have every year and learn directly about dermatology. There are videos for the lay public about common disorders. So there are many efforts, I'm sure I'm not remembering all of them, that the society is actively engaged in to reduce racial disparities. One I have to point out is right on the website is a section for medical students who are interested in matching in dermatology. And it provides for them step by step, year by year, a roadmap of what they need to do if they want to have a successful application to dermatology. So those are just some of the efforts of the society.
That's very interesting. Thank you for that recap of what's going on in this area. I was wondering if the Skin of Color Society and other ethnic skin centers, how they can approach the disparity in residency programs, taking persons of color into their training programs in general dermatology.
Wow, that's a very loaded question right now. I think that it's important for the folks who run ethnic skin centers to be able to speak to the rest of the department about implicit bias. That's one of the biggest things that I think we have to get over in our department at Wake Forest, where we don't necessarily have an ethnic skin center, but they have me and several other folks who are interested in skin of color. We ask the folks who take part in the residency selection to take implicit bias testing each year, even if it's the same people. Every year we require that as part of our evaluation. That's just one of the things that we do. We also separate out the applications after they're reviewed to make sure that we've given underrepresented minority candidates a fair viewing, to make sure that we're not using criteria that are not fair or in some way biased in terms of our selection. And so I think that the folks who are running these ethnic skin centers are really the people that are going to help educate the rest of the department. It's just the same as any other interest. When you have great Mohs surgeons, when you have great pathologists, those people are going to educate you on how to be the best dermatologist you can be. And in the same way, these ethnic skin centers and those who run them are going to help educate the rest of the department about how to actually have an unbiased selection criteria so that we can get more folks into dermatology who have interest and knowledge about skin of color and who will go on to round out our specialty so that we don't have as many disparities in terms of access and assessment of disease. Another thing I'd like to add that the Skin of Color Society has done is I think it's heightened the need for this knowledge. And so it's made other programs that haven't necessarily been very diverse become more diverse. So larger meetings like the American Academy of Dermatology, other meetings around the country where previously perhaps they did not have anyone to discuss things going on in skin of color, have really started to reach out and to provide that information to practicing dermatologists. So I think as we go forward, we see more practicing dermatologists want to learn about it. We also know that folks are going to start being able to decrease bias if we have more and more ethnic skin centers popping up. And I think we'll be able to get more dermatologists who are from underrepresented minorities into dermatology. And I think all of that's going to come together nicely if we work towards that goal. I don't think we can take our eye off the ball, but I think we're on the road to that happening.
So one last question for the three of you. There are dermatologists out there, and they're asking, what can I do to make a positive impact? Any advice for them?
I think that there are a myriad of opportunities for the practicing dermatologist to make substantial improvements. So number one, many people complain about the pipeline, that there aren't as many diverse candidates and that we have to increase the pipeline. Well, how do you do that? Well, the way you do that is you can mentor a high school, college, or medical student. You can have them come and shadow you. You can help provide research opportunities to publish papers or case reports, expose and mentor these students. There are many bright students who don't have social capital. They've not been around a medical environment. They don't necessarily know how to interview and can learn so much from dermatologists. We're very fortunate in that dermatology is a very lucrative field. So it behooves us all to contribute. You can contribute a gift to a Skin of Color Society. You can give a gift to Women's Derm Society, the AAD, all of whom have mentorship programs that provide money for students to do research and to travel. Those are just a couple of the opportunities that are available for dermatologists to really make a difference in this field.
This is Amy McMichael again. I agree completely with Dr. Taylor's assessment. I would also add that the practicing dermatologists out there can look at guidelines for cultural competency. It's not something that we bring up often, but there is a nice paper that Dr. Amit Pandya was really spearheading, and I was one of the authors on that paper. But it really talks about the things that you can do as a practicing physician, practicing dermatologist, to be culturally competent. So you can be great at what you do, you could be a fantastic dermatologist, but still not be culturally competent. So looking at what that really means, how to understand populations that are different from you culturally, how to look at perhaps having individuals in your practice that can make those patients more comfortable in your practice, whether they may be your nurses or your intake people, your back office folks, just sort of looking around and seeing how you can diversify your own space so that when others come, they feel like you know what you're talking about. And I think that's really the goal overall.
Okay, so this has been an incredible discussion about a very complex subject. I want to thank the three of you for joining us today and giving us of your time. And as the editor of Cutis, I'd like to say that we are really proud and happy to collaborate with the Skin of Color Society, and that I suggest our listeners look for their columns in this issue as well as future issues. So thank you all again for joining us.
And that concludes episode 72 of Dermatology Weekly. Dermatology Weekly is produced by MD Edge editors Elizabeth Meshkati and Melissa Sears. All MD Edge podcasts are produced by MD Edge executive editor Kathy Skarbeck and senior vice president of Medscape, Dr. Ivan Aransky. Show notes are authored by Melissa Sears, and the audio editor and audio engineer for Dermatology Weekly is Tyler Mundek. I am the voice of Dermatology Weekly, Nick Andrews.